This podcast is intended to provide information for educational purposes only and to serve as a starting point for you to have a conversation with your personal physician. Nothing stated on this podcast should be considered medical advice. Consult with your physician before undertaking or changing any treatment plan.
Welcome back to the Pound of Cure Weight Loss Podcast. We are here for a special episode, including Deidre, our wonderful nurse practitioner, and we've got Dr. Weiner, of course, as well. Got it, the clan. We're only missing Sierra. She was kind of busy today, but we have a good episode today, something that you might find applicable for how you can get your hands on GLP-1 meds.
Yes, it's complicated, just a warning. I looked through the whole process, and I think, Deidre, you probably have the best understanding out of the three of us for sure about how this all works. Walk everybody through, and I'll just tell everybody, buckle in. And if you're expecting something simple that makes sense, Deidre's that's not what she's going to give you. So, Deidre, why don't you just kind of walk through how it all works, who it applies to, and give people a sense of how this what they can expect.
So what we're talking about today is the CMS, the Center for Medicaid Services Bridge Program. It is a limited program at this time. It's going to run through July 1st of 26 to December 31st of 2027. The program will have to be expanded after that time, and hopefully it will be. I'm hoping it's going to be super successful and they continue this. But right now it is going to be a limited run. So the way the program works is that if you meet the BMI and comorbidity qualifications for the program, you will be able to get Zepbound, quick pens, Wegovy, injector pens, or pills from the Center for Medicaid Services directly for a copay of $50 a month. Now, the qualifications are pretty steep, and also it's a two-part program. So the way it works is that if you are eligible to get GLP-1 medications, specifically Zepbound and Wegovy, through your current Medicare insurance for diagnoses like sleep apnea or non-alcoholic fatty liver, or diabetes, you will not be able to take advantage of this program. Also, this program is only for Medicare Part D clients. So if you have straight Medicare A and B, but then you have an employer plan or a plan for the VA, some sort of retirement plan.
Now, Medicare Part D, what is that again, Deidre?
So Medicare Part D is a standalone prescription plan that can be added on as a supplement to Medicare Part A and B that allows prescription coverage. Medicare Part A and B does not have prescription coverage, right? It only covers hospital costs and, medical,
Do you sign up for Medicare Part D? Is that like an extra sign up, or do you get it just because you're Medicare?
Maybe. So if you have Medicare Part A and B, you have to have a separate plan if you want to have prescription coverage. If you have a Medicare Advantage plan, Medicare Advantage is an all-in-one plan, so it covers A, B, and D. D comes automatically. Okay. You do not have to sign up separately for it. If you choose to do what's called a Medigap or Medicare supplement plan, which is the same type of plan, you have to choose what prescription plan you have. Now, most patients or most clients do choose Part D because if you do not have Part D, then you have to pay a penalty on your Medicare A and B coverage when you do sign up for a prescription plan. However, if you have the VA or an employer plan or a retirement systems plan, you might not have Part D.
Right. Because first of all, most people have Medicare Advantage, right? So if you have Medicare Advantage, AARP, or one of those plans that's kind of an all-in-one Medicare plan, you're in.
Probably going to have it.
And then if you have straight Medicare and you A and B, and you elected a Part D plan, what about like the state-supported plans that we'll see sometimes?
That's what I was saying, is that a lot of those state-supported plans are not Part D.
Okay.
So we have to check.
And they're not considered Medicare Advantage plans.
Right.
So but they can opt into signing up for the Part D plan part.
They can do it as a standalone plan. So there is a criteria. I mean, there is a list of, what insurances are covered and which are not covered. through our program, I mean, that'll be the first step, is just to check to make sure you have Part D coverage. For instance,
Yeah.
I had a patient today that had Medicare A and B, but then she had a federal retirement plan, and that did not have Part D on it. So she's
Is
not
there a
gonna get.
single place you can go? Like, let's say I'm a Medicare recipient. Can I
Yes.
go to a website, put in my name, social security number, something like that? I saw something in the documents about Relay Health.
Medicare.gov. You can go to Medicare.gov and you can put in your
Okay.
social security number or your plan, and it will tell you, it will give you the plan documents.
Okay.
However, it's not super clear. I did do a run
Yeah, of
through
course
on it
not.
just to see how it worked. Right. I actually had to go into I had to open the plan documents. It didn't just tell me that Part D was included. I had to go into the plan documents and read them. So going through that on your own might be a little tricky, but our for instance, for our program, and hopefully other offices will be set up to be able to check those benefits, in a more straight,
Yeah.
straight line fashion. But there's not a specific place that you can just type in your plan and say, does this have Part D coverage?
Yeah. I
So,
think a really important piece for anybody listening is that my take on this is that this has not been rolled out in a particularly well thought out or simple manner. And that's not uncommon. First of all, it's not uncommon in healthcare. It's not a ding against Medicare or the government. Just nothing in healthcare is transparent or easy to use. But this program has not, in my opinion, been rolled out in that fashion. Now, we also, on our website, poundingyourweightloss.com, we do have a tool that allows you to go in and check your comorbid conditions, and we're going to be continuing to work on this tool. So it is live right now. But as we learn more, we're a very tech savvy business. Anybody in our practice, any of our patients know that, don't ever get used to our portal or how we do things, because it's constantly evolving and changing. We like to think it's improving. I understand the other perspective, which is it's changing. But we are all over this and already have a tool. And as we learn more, we'll be building that tool out further. My hope is that we can create a system where you can literally come to our website, one stop, and just be like, hey, here's my deal, here's my Medicare card or something like that, and you upload it, and we're able to give you information about whether or not you're covered. So just keep an eye on that. And if that doesn't give you the answer, check back in a few weeks, because we'll be changing it and improving it.
the big stopgap is going to be if you have Part D. If you don't have Part
Yeah.
D coverage, then there is no option for you.
Yeah.
I mean, there is an option for coverage if you have sleep apnea, non-alcoholic fatty liver, or
Yeah.
diabetes, or
But
or a self-pay plan.
most people
But
do
without
have Part D coverage, right?
most people do, most people do have Part D coverage, yes,
Yeah.
and you can purchase Part D as a standalone plan as well. So for
But
most
only
people,
at
this will
certain
be an
times, right?
only during open enrollment
Yeah, which is
periods.
usually the end of the
During
year, November-ish.
November,
Yeah.
end of October, beginning of November, and December, and then there is a small open enrollment period, like in March, I think, February or March, where if you're changing plans, you might have an option to change based on your
Okay.
circumstances. But yeah, the
So
main
if you're
enrollment
not
period
a
is November.
candidate, then you're going to have an opportunity to switch, around November.
Right,
That's certainly
right.
something we'll be covering, and by November, I think we'll have a really good handle on how this program works.
I mean, because yeah, absolutely. We will have done lots of authorizations.
Yeah,
Now, who is a candidate? That's important.
yeah,
So the comorbidity qualifications for the Bridge program are fairly strict. You have
yeah,
a BMI of 35 or above with no comorbidities.
right.
Many patients are in the in-between categories, though, in terms of their BMI. So with a BMI of 32 to 35, the Medicare program will cover patients who have a previous heart attack or stroke, peripheral arterial disease with prior procedure, or a high brachial plexus index, and that is not common. We're
Is that
talking
the
people.
ABIs, the arterial brachial index that they check?
Yeah, well, we're talking like people who have arterial, like coronary artery stents or aortic
Okay.
stents, things
Or
like that,
peripheral
right?
vascular disease.
Or nope, not vascular, only arterial disease. So not venous disease, only
Right, but
arterial disease.
peripheral arterial disease will count.
Right,
So like
right.
if I have had a fempop bypass because I have an obstruction
Yes,
in my leg.
yes, that
Okay.
would count. Yeah.
And how do they measure that? Is it ABIs that they use? Ankle brachial index?
Yes, that's what it is. The
Okay.
ankle index. Yeah.
The ankle brachial
And
index. Okay.
yeah,
We'll have
or
to put our vascular surgery colleagues on notice.
right.
Yeah.
Or you can have uncontrolled hypertension on 2 medications and still have a blood pressure over 140/90. So that's,
Okay.
not going to be a lot of people probably. You can
Well,
also go.
but in Arizona, it's 108 degrees out. And if you just right before you come into the office, sit outside for an extra 2 or 3 minutes,
That will help your blood
chances
pressure.
are you get that blood pressure up to 145/95
Well,
when we sit down to check it.
you already have to be on 2 medications as well.
Yeah,
So
yeah. I'm kidding. Don't do that. That's insurance fraud. But
and then so it does go one step lower though. You can also have a BMI of 27 or above, and with that is the same cardiovascular comorbidities, previous heart attack, stroke, peripheral arterial disease, uncontrolled hypertension, but they've also added prediabetes to that.
Right.
Now that opens up the coverage because a lot of
Yeah.
patients out there have prediabetes. It's fairly common. All we need is a recent lab result.
what's their A1C criteria for that?
5.6 or above. 5.6
Ah.
or above. Yeah.
Oh, man.
So that is pretty. That's
That's where we'll get a lot of
that's the
people,
way to
hopefully.
open up
Yeah.
that. And
Yeah.
they will be going. Well, we don't know this for sure yet, but according to the CMS website, they will be using your initial BMI from when you started GLP-1s if you're already on a GLP-1.
Yeah, that's going to be a big issue, especially our self-pay patients and our dilution
Right.
patients.
Right.
Yeah.
So now, if you can get your medication covered through your Part D benefit using another comorbidity, specifically diabetes, which is an A1C of 6.5 or above, moderate to severe obstructive sleep apnea, or moderate to severe liver fibrosis as a result of non-alcoholic fatty liver, you cannot use the Bridge program, even if it's less expensive. If you can get qualified through your regular Part D benefit, which many people have already been getting GLP-1s with those comorbidities, then you are not eligible to take advantage of the Bridge program.
And so that's where the whole you got to first get it denied
Right.
and then resubmit comes in.
the
So
way the system
walk through
works
that
is-
because that is super confusing. I
It's
mean,
very confusing. It's what's
yeah.
going to make this so complicated. What you have to do, what the prior authorization process is a 2-step process. The script first has to be submitted to your pharmacy under your current insurance plan and Part D plan. So under your regular ARP Advantage plan or whatever insurance plan you have, with any applicable comorbidities and a special code saying that it's destined for the Bridge program.
Right.
It then has to be, the authorization has to be run by by the pharmacy. It has to be denied. Once the pharmacy gets the denial, they will send it back to us, and we will rerun the authorization through the Center for Medicaid Services with another special code. And then we will have to wait for a return authorization from the Center for Medicaid Services. Any time you use the Bridge program, the $50 a month that you pay will not go towards your insurance deductible. So if you have a prescription deductible through your Medicare plan, Advantage plans, supplement plans, they typically do have prescription deductibles, especially supplement plans. The $50 a month that you pay for the CMS Bridge program will not go towards that.
Yeah.
If you are on a low income subsidy program, which some Medicare patients are, including Medicare dual complete patients who are eligible for the Bridge program, they have Part D, but they will have to pay the $50 copay and will not be able to use a discount card. Manufacturer's discount coupons, not applicable. So it's $50 a month, flat fee.
No matter
no
what.
Discounts,
Yeah.
no matter what.
So
So
that's cuts both ways though, really.
Right.
There are some patients who, let's say you're on a really expensive medication, you're hitting your Medicare deductible, your GLP-1 is essentially free because you hit your deductible with your other expensive medication. And so the GLP-1 is free. But we have a ton of patients who are like in January and February, they're paying like $500 or $600 every time they go to the pharmacy for the first few months. And then they hit their deductible, and then it's essentially $25 or something reasonable after that. And so for the first group of patients where they have an expensive medication, the Bridge program doesn't count that, and it's an extra $50 a month. And so for them, it's going to be more expensive. For patients who don't have another expensive medication, then it will be cheaper.
For patients who are already getting their GLP-1s with one of those other diagnoses that we talked about, sleep apnea, diabetes, or the non-alcoholic fatty liver, their copays, especially if they have a supplement plan, a Medigap plan, may still be like $500 a month. But they are not eligible for the Bridge program, so even though it's less expensive, they cannot take advantage of that. And that's going, that's a disadvantage for a lot of patients. So, but not for everybody. So
yeah. But I mean, there seems like there's a lot of hoops to jump through. But if you fit those criteria, then you will have found the loophole to get yourself through and get these meds for $50 a month.
Right, which would be fantastic.
Yeah.
So.
And we're working on making sure that, we can help as many people who do qualify get them for that price as possible.
Yeah. Zoe, now there's also a requirement that you participate in a nutrition program, correct? Why don't you tell us what that's all about?
Yes. So in order to qualify, you also have to be part of a structured lifestyle modification and nutrition program. Now, this is something that we already have implemented in our practice, of course, with our app, Loli, and also all of the work that I do with patients and, obviously what we have available to everyone, like I said, through the app. But having that structured program and the documentation to support that you are actively working on your nutrition and exercise and other lifestyle factors in congruency with the medication, not just relying on the medication alone.
Yeah. Which goes along with pretty much everything we've ever said on this podcast.
Right.
Right. But I have to say, I'm actually appreciative that this Bridge program calls that out because, like you said, we've been talking about the importance of that for forever. However, having that also be mirrored in this bigger program, because that's what we see in the studies that show the best results with the GLP-1s, of course, is that combination with lifestyle modification. So, having that pointed out as part of the requirements for the program, I think is a really good call on their end.
Yeah. I think anybody who's listening is going to come to the conclusion that this is probably not something your PCP is going to be able to do for you. Right. I mean, first of all, the PCP doesn't have that program for the nutrition already in place, so you're going to have to kind of outsource that and figure that out yourself. I could see a lot of audits coming. I could see them, you go for your refill and they're like, oh, sorry, you didn't submit any documentation that shows that you participated in a nutrition program. I mean, this is what happens all the time on our back end. This is a little bit more of a consumer-facing program, so I could kind of see them passing some of those responsibilities onto their Medicare recipients, and so you guys will all get a taste of what we kind of fight against every day in terms of kind of spontaneous denials and nonsensical responses to your applications and prior auth submissions. And the second piece is this, you really almost have to fill out 2 prior auths. It kind of sounds like you may have to fill it out you have to fill it out the first time for fatty liver disease, sleep apnea, and diabetes. Get that denied, then submit a second prior auth to a second entity. It's not even just pushing it back to the pharmacy. It has to go to Medicare directly. It almost seems like you need to be like a super AI powered practice to be able to figure this out. Would that be accurate?
Absolutely. A PCP.
Yeah, if anybody knows any out there.
They don't. Yeah. They just don't have the resources or the follow up to be able to do this kind of 2-step authorization process. But so it's really important to be enrolled in a weight loss specific program that includes a nutrition component, which of course Pound of Cure is all of that. Yeah. And we will be working, we already have put steps in place to, automate this process so that there's follow through and there's not people are getting dropped in between the dual authorization process. And we are already well versed in what comorbidities qualify, how to find those comorbidities, what documentation is needed. We do this every day already with Medicare.
I think that, so if you're out there listening, I'll talk to you a little bit about what our practice is going to do. And we have a meeting in, another half hour that we're going to really spell this out. But essentially our practice obviously is gearing up for this. We anticipate that there will be a lot of people who are interested in this bridge program. The first thing is that we are initially only going to limit this to Arizona residents. I'm not happy about that, but that is what our attorney has essentially said that we have to do as we get started. We will ultimately, our goal is to branch out beyond Arizona. The states that we've worked in the past would most likely be the ones we reach out to, which is California, New York, Florida, Michigan, right? And New York. And so those will probably be the next states that we do this to. I think another important thing is the idea that you're going to show up on July 2nd. The program starts on July 1st, and we're going to write you a prescription, and you're going to go down to the pharmacy that afternoon and pick it up. It's not how it's going to work. I would anticipate at least a 30-day wait. So if you're using our dilution approach, make sure you've got supplies to get through that. If just make sure your expectations are in line with that, because it's not going to be possible to deliver an expedited approval. I think that's the first. And then the second thing is expect there to be some degree of confusion in this process. Mm-hmm. It's very complicated, but we are working very hard, and we have implemented a lot of AI into our practice. Any new patients have seen this in our forms that used to be, as our receptionist used to describe, a lengthy 72-question intake process was how he would describe that, and it wasn't inaccurate. That was not an inaccurate assessment. Yeah, is now a chat bot where you take a picture of your driver's license and your insurance card, and that's all you need to do. And so we've streamlined a lot of this, but it's not quite there yet. So it's going to take us a month or two to really get this implemented, streamlined on our end as we learn about it, the process, build out the systems to support it, make sure our staff are trained and everything like that. So I asked everybody out there, if you are interested, you can actually book appointments through our website for this. But make sure you understand that, July is a learning month for us. And we're hoping toward the end of the summer and to the fall that we've kind of got this whole thing automated. But we do have all the pieces in place, yeah.
I imagine it's not going to be a learning curve only for us, but also with this being a new program. Yeah. I'm sure that they're going to try figure out, okay, how do we do this? What that turnaround time is going to be. So it's going to be we're figuring out as they're figuring it out.
Right. Pharmacies have got to figure it out.
Pharmacies especially. Yeah.
Now, who fills it? Is it mail order through Lilly Direct and Novo Care?
No, you can get it through your regular pharmacy.
Okay, so you get it through your regular pharmacy. So your regular pharmacy will get the prior auth acceptance from CMS.
Right.
Okay.
I mean, we will also be notified of the CMS prior auth acceptance as well, because we're the ones submitting that. But the pharmacy will at the same time, and the pharmacy who does the initial prior auth, and we do the secondary prior auth.
No.
So. Again, it's going to be a learning curve. Pharmacies are going to be very overwhelmed because this program is already popular. There are TV commercials about it. I've had patients, half my patients every day want to talk about the Bridge program. So it's going to be, every system is going to be overwhelmed at first. So.
Yeah. What about drug shortages? Do you think we'll see drug shortages again?
I hope not, because many of these patients are already taking these medications in self-pay form, at least in our practice. And the drug shortages were really in the very, 2 or 3 years ago, when it was actually the injector pen method was the problem and not the medication itself.
Yeah.
I think after those initial shortages, they really amped up the production. They introduced vials, Eli Lilly introduced vials. Novo Nordisk really ramped up their production for the injector pens. And, now they have pills available. I think that there's just a lot more supply. So I don't think that there's going to be a drug shortage issue. I think the issue is going to be just complexity at every step of the process.
Yeah.
It has to be
Paperwork.
back right to the pharmacy. The pharmacy is going to be overwhelmed. Did it get submitted correctly? Did the denial get back to us for us to resubmit to the CMS program? Many times pharmacies will be like, "Oh, we sent you a prior auth request and nobody ever did," So then we have to resubmit to CMS, then CMS to get back to us. I mean, every step of the process is complex. It's going to require exact wording, specific codes, and so we've been doing this for a while, until everybody has been doing this for a while, there's going to be hiccups, and it's going to take extra time probably.
Yeah.
So
I wonder realistically, because of kind of the tightened down criteria, I wonder how many people who are not currently taking a GLP-1 but want to are going to be taking them for the first time with this bridge program. I feel like it's probably, you think it's going to be a lot or not a lot of people?
The BMI 27 with diabetes, pre-diabetes, is really going to open up
a lot of people.
A big window. It's a lot of people. But we'll see. The question is, certainly they'll need recent labs. They're going to be strict on documentation. We don't know exactly how it's going to work, but I think that a fair amount of people will be able to get new coverage that have not been able to be covered before. So.
And it'd probably be a good idea to get established with your preferred weight loss practice now, so that by the time, so you kind of have all of those pieces of your puzzle already in place, and then that once the program opens, then you can kind of start that conversation.
We're already checking for those things. We're already checking for labs. We're already checking to see if you've ever been tested for sleep apnea. We're already checking to see if you've ever seen a liver specialist. We're already on the lookout for
and then flagging those people.
Cardiovascular comorbidities. We're already looking for those things. So if the earlier you get in with a weight loss specialist, then the greater chance you have of getting coverage, and the less time it will take, because if you have to do any extra testing. So
exactly.
We'll get extra documentation.
Yeah.
So get your
if you're out there, you can book appointments through our website with Deidre for new non-surgical patients. One thing we will be implementing also, I didn't mention it, but we're really going to be restricting this program to telemedicine, especially because of the administrative cost. And you can imagine, people won't fill out these prior auths for us for free, right? We have to hire staff. It's use software. There's a lot of expenses on our end. Office visits are more labor intensive than telemed visits, and so we will be restricting this to telemed only visits. And our website, you can only book telemed for non-surgical patients. Surgical patients we still will happily see in the office. But for GLP-1 Bridge Program type patients, it's telemedicine only in our practice for that. And you have to also be an Arizona resident, as I mentioned earlier. But I think this is a good thing. Zoe, I think there's a lot of people who will use this medication because it puts a concrete price on it, right? Everybody out there is like, oh my God, it's so expensive. I can't afford that. And now it's like it's $50 a month. All right, I can afford $50 a month. And so I think it's changed it from expensive, which is what most people think. And again, keep in mind, in our program, we can get anybody with access patients or Medicaid patients as an exception because there's a lot of rules around there. But if you're not a Medicaid or access patient, you can basically, our top price, well, you can spend more, but we can get people on a decent GLP-1 dose, all in, visits, nutrition, the medication, everything. It's about $225 a month. So that, I'm not saying that's cheap, but that certainly is in a lot of people's price range for these meds. So, and that's what some of our Medicare patients have been paying, is around that much. And so that goes down to $50 a month if you're a Medicare patient. If you're a commercial patient, it's still $225, and so that's also available through our practice too.
And that's less than what a lot of people were paying when they were going to compounding, like
Absolutely.
med
Oh,
spas
yeah.
for the compounding medications.
Yep, absolutely.
Only recently have I seen compounding patients get it cheaper. But a lot of times they're getting like a small dose.
Right.
And it's really semaglutide, not tirzepatide. Tirzepatide,
And I think 'cause those
is
places
still
are
cheaper through a
scrambling.
dilution. They're scrambling,
for
and
business.
yeah, and also it's just getting sketchier and sketchier, the compounding space. Again, I think we've just explained our stance on compounding. We're not necessarily against it. I don't think it's the cheapest way to do it most of the time, and wouldn't you rather get real medicine for less money than fake medicine for more money? That's what we've been seeing most of the time in our practice when people come to us from compounding pharmacies. So,
Something I was just thinking about that I wanted your guys' opinion on. If, obviously we are going to be servicing firstly Arizona patients for this program. However, since our nutrition program and our app, Loli Weight Loss, is available for people all over the country, I'm wondering how they can use that structured nutrition program as their requirement for their bridge program if they're living in Arkansas.
yeah.
What do you think that looks like?
They could have an external nutrition membership. They get, the nutrition program is nationwide. You can get a membership in any state, from
Right.
any
Yeah.
state, and
It's just the prescriptions,
You can provide
Arizona only.
documentation to combine that with an authorization from another weight loss provider in Arkansas or wherever you are. The external membership for the nutrition program pricing is a little bit different than our in-state patient pricing, but still very reasonable. And also, you still get all the same resources as our patients do, which is, human visits with a dietitian, Zoe, our AI dietitian as well, Loli, food tracking resources, educational resources. I mean, it's a very thorough nutrition program, tailored to bariatrics, bariatric surgery, and GLP-1 medications. And so I think you would be able to combine it with documentation.
Yeah, documentation
We're
piece.
going to be submitting a packet to the CMS Bridge program. They've given some guidelines on what they want in the packet, and that could be part of the packet probably.
Yeah. I see us having a special for the Bridge program, lowering our pricing a little bit so that people can use our Loli tool. But the more time I spend with the more time I spend with GLP-1 patients, the more I realize for the majority, there's 15%, doesn't matter what they do. They can eat, just food, the nutrition's taken care of. They don't really have to worry. But for 85% of people, what you eat makes a huge difference in your success and how in your lifestyle. And so side effects for sure, everybody's side effects, but weight loss too. And so I think
And weight weight maintenance, building healthy habits to keep that weight off.
All of it.
I want to share a little aside real quick. I was talking with a patient actually today through the app, through Loli. He booked an office hours appointment, which is available to any of our Loli members. But he was telling me about how he was so pleasantly surprised because he was tracking his food using our app. And if you're unfamiliar or you haven't used the food tracking part of our app before, you literally just take a picture and then the AI analyzes it and tracks it. And we don't count calories, but we measure the quality of the calories. So regardless, he was telling me he had jackfruit carnitas tacos at a place, and he was like, I don't think they're going to be able to get this, but let me just see. And he snapped a picture, and he was beside himself because it tracked it perfectly, and it knew that it was jackfruit. And I was just like, I love that so much. That's impressive. I know. I need to share that with the team.
Yeah. When I was in Guatemala, it was getting it right, with Guatemalan food. So yeah, the image tracker and our ability to track food and measure quality, it's pretty awesome. But anyway, all right. Well, the Medicare Part the Part D Bridge program starts July 1st, and I think we've got our work cut out for us, don't we, as a practice to get set up for this.
Definitely, but I think we're better equipped than probably anybody else to handle it. So
It's true.
For sure.
Yep.
For sure.
All right, great conversation, guys. Thanks for being here. And if you listening know anybody who might be interested in learning about the Bridge program, or has you have had conversations, questions, send this episode their way, and we're excited to figure this out together.
Yes.
thanks.
All right, see you guys next time.
Bye.